Wow, that was a tour de force with a lot of information, but I think you'll understand to begin with that we've now moved on and are putting more pieces together. Uh, we have with us today one of our patients who is one of the first patients to ever go on to just 2 drugs together and show us how well it works. And you missed one of these trials that Dr. Sullivan is also working on is now not just the PD-1, not just the CTLA-4, but also adding the LAG-3 and an extra IL-6 inhibitor to decrease toxicity, increase efficacy. And this is not a novel idea. It's just an idea that has to be nurtured through places like MD Anderson and Mass General, and through the research and through the patients' involvement in these trials, how to make things better, less harmful, because the last slide shows where we want to be. We want to have our nutritionist give you something for the microbiome. We want to have our health advocate tell you how much you need to exercise to get the immune system going. We need to have the right therapies. You need to give us some of your blood and your hair and everything so we can just personalize it so the geneticist can help. So a whole team will then take care of you. And then, of course, a mani-pedi at the same time. But that's the future and where we've gone to. Just this meeting is not just an educational thing, it's a mandate for the physicians who show up here to go back and give us more information or something new for next year, but one of the newest information and the hottest information comes from work that's been done through the Southwest Oncology group, SWOG, looking at what's the best way to treat someone who has localized melanoma, and the words that we never talked about, adjuvant and neoadjuvant, and the clinical trials that are there. Dr. Mehmi is going to come up and give us that talk, but it will reference a lot of the work that Dr. Patel has done and led in her role as president of SWOG. So I'd like to bring up Dr. Mehmi to give us that information and explain it all.
Hey, good morning. Thank you for letting me say a few words on the work that Dr. Patel and others have done. I'm a huge fan of you. So today, Just has already set up a perfect stage in terms of what immunotherapy is and what does it mean in melanoma in advanced setting. I think just like all the other malignancies, new drugs are tried in advanced stages, and then we take a step back and think, can we prevent the advanced stage from even showing up? Can we try these drugs that are so impactful in stage 4 disease? Is it possible to bring them in earlier and not allow for that stage 4 to even happen? And that's what we're going to talk about today. I'm talking about function of immunotherapy in pre-surgery or post-surgery setting, meaning somebody who has either lymph node negative, high-risk melanoma of the skin, or lymph node positive melanoma that carries a fairly high risk of recurrences, meaning the disease coming back and causing morbidities, mortalities, and those kind of issues. And can we change that paradigm? So these are the objectives of my talk today. Just wanted to give you a little sort of glimpse into what was and what is in melanoma. And if you look at back in the 70s, we only had dacarbazine, alkylating cytotoxic chemotherapy, didn't really work all that well, was very toxic. And then came along some of the cytokines, the interleukins, the interferons. Those too were toxic, poorly tolerated, and benefit was limited. Then there was an explosion of therapies when you're looking at in the 2000s from targeted therapies to immunotherapies. And now we're looking at combinations, new checkpoint inhibitors, newer combination, new ways to give those drugs to reduce the toxicity and keeping their benefit intact. So first few minutes I will spend on looking at traditional adjuvant setting immunotherapeutics in early stage melanoma with high risk node negative disease, which is 2B, 2C. And then we'll take a look at some of the trials that have happened and the results have been reported. FDA approval has been granted for node positive disease. And then what's coming down the pike in future trials. And then hopefully I'll have more than enough time to spend on neoadjuvant approach. That is essentially is the latest thing, probably the greatest thing in melanoma, in my opinion. Excuse me. So we'll dive right into it. This is the one of the studies that I'm highlighting, looking at stage 2B, 2C disease, which is sentinel lymph node negative melanoma, still carries a fairly high risk of recurrences, looking at 976 patients that were treated with pembrolizumab or placebo, and some of the characteristics of those patients are highlighted there. And at the first interim analysis, you see that there is a reduced risk of recurrences in patients treated with pembrolizumab. At the second interim analysis, again, it showed that there was improved relapse-free survival or recurrence risks were decreased with pembrolizumab. And I think one of the things that we need to highlight, not only that these therapies are effective in that setting, they're also fairly well tolerated. Most of the time, these PD-1s or pembrolizumabs or nivolumabs, single agents, are easily tolerated. Most common adverse events tend to be fatigue, joint aches and pains, muscle aches and pains, sort of, flu-like symptoms kind of thing, but most of the time it's well tolerated. There are some high-risk toxicity that are possible, but most of the time they tend not to happen as frequently, allowing this to be a more than reasonable therapy for a lot of the patient population with this particular stage of disease. So jump into high-risk node positive disease. This is one of the older studies looking at ipilimumab versus placebo in node positive disease. The phase 3 study looked at, close to 1,000 patients randomized to either 10 milligram per kilogram ipilimumab, which is also Yervoy, versus placebo. And with the primary endpoint of relapse-free survival, the 5-year RFS rate was 40% with ipi and 30% for placebo. And then also there was a secondary endpoint of overall survival advantage. Does giving this particular drug, ipilimumab, makes you live longer? And that was the case. And the challenge with ipilimumab, as Justin described, is the toxicity at particularly 10 milligram per kilogram dose. And it is one of the toxic drugs, leading to well over 50% rate of toxicity versus placebo. But this is probably, it is one of the first drugs that established overall survival in adjuvant setting in melanoma. So next question is there something better? Is there a drug that really help us decrease risk of recurrences but not be as toxic? And that is precisely the trial that looked at this particular question in Checkmate 238. And that particular study randomized 960 patients to either ipi or nivo, and with the primary endpoint of RFS, which is relapse-free survival. And again, the goal was accomplished. And on top of it, not only nivolumab was better in terms of RFS benefit, it's also a lot less toxic. Again, taking the step of improving therapy from the point of view tolerance and also from benefit as well. So not to be outdone by one pharma, and so you have a competitor and looking at pembrolizumab in node positive high risk disease, and these patients were either getting pembrolizumab or placebo in a phase 3 double-blinded placebo-controlled trial in high risk melanoma. Again, pembrolizumab was very effective in decreasing risk of recurrences and overall very, very well tolerated in terms of toxicity profile. So some of the patients may not be candidate for nivolumab or pembrolizumab or any other immunotherapies because they have autoimmune disease issues or some other issues, and that doesn't allow them to be a candidate for immunotherapeutics. And do they have an option? So as you know, about 40 to 45% of the cutaneous melanoma patients carry a BRAF mutations, the V600E or K, that is very targetable with the combination targeted therapy. Vemurafenib, cobimetinib, in metastatic setting is approved. Encorafenib, binimetinib in metastatic setting is approved. And trametinib, dabrafenib is also approved in metastatic setting. And that was also studied in earlier stage disease, looking at phase 3 double-blinded placebo-controlled study in mutated melanoma with the V600E or K. And again, primary endpoint was 3-year RFS, and that was achieved by the combination, and all the trend towards overall survival advantage. This therapy, again, is reasonably well tolerated. Most common adverse event tends to be fever, arthralgias, and myalgias, but either using antipyretics like Tylenol or ibuprofens, you tend to reduce that toxicity, or if it continues to occur, dose reduction and some other at times, we review low-dose prednisone to reduce those sporadic events. So this is the latest and greatest. It was recently presented by Dr. Weber at the AACR conference. It happened about a month ago. This is Moderna's mRNA-4157 with or without pembrolizumab. It's a personalized. This is as personalized a cancer therapy gets. On the left bottom is essentially a schematic of what this mRNA vaccine is. You obtain patient's tumor sample, and then you isolate the RNA, and that RNA and some of that information is fed into a computer algorithm. Then it spits out about 34 different neoantigens, pieces of information that our immune system can take, learn, and then survey for melanoma. And that then is given back to the patient. That vaccine is given back to the patient to reduce the risk of recurrences. So in my opinion, this is not a true adjuvant study. This is almost a neoadjuvant study, but you're giving those neoantigens after the surgery. You are giving that tumor information to the immune system. Versus traditional adjuvant studies where resection and a drug that doesn't really give any direct tumoral information to the immune system. So this study actually looked at, so that's a schema of the study that I just told you about, and some of the key eligibility criteria that these were very high risk for recurrences melanoma. Node positive, palpable, meaning you could feel the nodes or you could detect them on scans. Again, they needed to be cutaneous melanomas and no prior therapy, had gone through surgery and so forth. And they were 2-to-1 randomized, meaning the vaccine with the pembrolizumab with two times as many patients versus the control arm, with the primary endpoint of relapse-free survival, with the secondary endpoint being distance metastases survival, safety, and tolerability of the therapy in a follow-up of 3-year period. So they screened 224 patients, and out of them, 150 were randomly assigned to either the treatment arm or the control. So there on the upper left is the patient demographics, fairly well balanced in both of the arms. And then you're on the right, you're seeing the benefit of combination arm, which is better than pembrolizumab alone, meaning that if you take this approach where you design an mRNA vaccine, combine it with Keytruda or pembrolizumab, and you give that to patient, and their relapse-free is much better compared to pembrolizumab alone. On top, again, the theme is we have all these therapies. Are they easy to take? Are they safe to take? The toxicity profile in both arms were fairly similar. We didn't see any newer signals. So that's another great sort of, advantage for the patients. So what are we doing for the future? There are new, so one of the trials that just completed is nivolumab with relatlimab that Dr. Moyers had talked about in metastatic setting, showing benefit with PFS. Now we're looking at that particular combination in adjuvant setting, meaning after surgery, and that was completed and we're waiting for the results for it. This study by Merck MK7684A010, this particular study is looking at high-risk melanomas that have been surgically removed and treating these patients with anti-TIGIT antibody, which is MK7684A, in combination with pembrolizumab versus pembrolizumab alone. This study is actively accruing, and we look forward to its results in the future. All right, so this, I think I have a few more minutes left, and I'm going to talk about neoadjuvant approach. So what is neoadjuvant approach versus adjuvant alone? On the top schematic, you see that a patient has a tumor and it's removed surgically, and then we treat it with immunotherapy in the sort of post-surgical setting. And in that setting, the amount of tumor information, in a sense, the neoantigens, our immune system's ability to identify tumor is limited because that tumor has been removed. It doesn't have access to that live tumor anymore. So as you can imagine, without that information, the immune system function may be slightly limited versus the depiction below, where you're looking at an intact tumor within the body, and you're giving a drug to allow the immune system to be active against, and now our active immune system has access to all that tumor information, these antigens, the ability to recognize these tumors and hopefully eradicate. So that's the preoperative or neoadjuvant approach. Okay, there have been a number of different trials that have happened in this space, and we'll talk a little bit about them. So this is, a sort of a number of different trials were put together, and that together data shows that if you take this approach, you treat these patients with a neoadjuvant or pre-surgically, and you can have their tumor respond, meaning decrease in size or completely go away. Those are the individuals that have the longest survival versus the ones that don't have response to their tumor. So not only it matters that you give the drug pre-surgically, it also matters that that tumor responds to that therapy. So we'll talk about that. There are a couple of terms that I'd like to define before we move further. There's the term PCR, pathological complete response, meaning that there's a tumor X located on the arm, for example, and we gave neoadjuvant immunotherapy, and then the patient goes for surgery. At the time, the surgeon removes the area where the tumor was or may still be, and then the pathologist looks under the microscope on that sample for any evidence for melanoma cells. If the pathologist finds no evidence, or less than 10% of whatever's left is the tumor cells, that is essentially complete pathological response. There is no more tumor left, meaning that's the highest sort of response you can imagine in that setting. But if there is still some tumor left and there's more tumor than you'd want, that's a not pathological complete response. Those individuals don't do as well. So allows us to learn more and possibly add in therapies that would get them to sort of be in that relapse-free survival period as well. So Prado was one of the studies with that intent, looking at 90 patients of 113, assessed for major pathological response, meaning at the time of pathological review, less than 10% of the residual melanoma was left in 60 patients, and 59 of them went on to get complete, they did not have any lymph node dissection. About 11 had partial response that pathologically determined, and 19 had no response. Again, goes to say that the individuals who had major pathological response had not only they did well in the long run, they didn't require major surgeries. You could avoid some of these therapies. So now we're talking about not only treating them up front prior to surgery, now we're also talking, can we limit the amount of therapy they require, but still keep them in the same benefit range that we've seen before? So a lot of new topics. Here you see that patients who had major pathological response, that's the green line up top, those are the ones that continue to do better without any disease recurrences. The one pink line is the one that didn't have, they're sort of in the middle, they still have some amount of tumor left. Those do better than the ones that had a lot of tumor left. So the response really matters. So this is probably one of the bigger child. This child's sort of idea was slightly different than just neoadjuvant therapy. What this child looked at was, what's better? Is it treating with immunotherapy after surgery better or before surgery better, right? And to address this, it's a SWOG study that looked at 345 patients and randomized 313 of them to either adjuvant arm or neoadjuvant arm, and then looked at their benefit. Baseline characteristics are given on the right and fairly even. And here's the impact of this particular approach, that when you're looking at these patients, the primary endpoint of event-free survival was significantly better with the neoadjuvant approach rather than the adjuvant approach, okay? And there's also overall survival advantage with this approach. And you're not adding any new therapies. These are the patients that we're gonna get pembrolizumab or another immunotherapy after surgery anyway. So why not give it first and have them do even better in the long run? So this is the other small study from MD Anderson, actually published, I think last year, looking at drug combination with nivolumab and relatlimab. Okay, again, same concept, treating patients with a high risk for recurrences disease upfront, and then they had amazing responses, 70% complete responses. I mean, these are numbers in melanoma that are unheard of. And on top of it, again, I keep coming back to the fact that not only that these are effective therapies, that these are tolerable therapies. So the future of neoadjuvant approach is shifting almost daily. Like I said earlier, not only we want these tumors eradicated, we also want our patients to sort of live their normal life. I don't want them to be married to the clinic and coming here every 3-4 weeks for their infusion and be reminded they have a certain disease, have that on their shoulder every single day, right? So this particular child is trying to accomplish that very much. Treat them up front, right? If they respond, if they have that pathological complete response, they will not need any additional adjuvant therapy. They're done. Okay. I mean, I don't think anybody thought that before, that you could just stop these therapies, that you don't have to. Like sometimes when we have these patients come in, even in advanced setting, they come in, they have complete response, PET scans negative after a year. It's like, okay, I think we can stop treatment. I think, but the society's built this idea that your cancer is only controlled if you continue to get therapy. We're changing that. And I get personally emotional about that. I don't know how you guys feel. I mean, to tell somebody you don't need this anymore, you're doing okay, you're going to be okay, and we have data to support that. It's no words. So the approach here, and we're also shifting. So what if somebody doesn't respond to neoadjuvant approach? I mean, the response rates are not 100%. So what do? Can we shift our gears? And this trial is allowing us to do that as well. If they don't have response the way we want them, and they have that BRAF mutation, we're allowed to change their from immunotherapy to targeted therapy to see if we can keep them controlled, to make sure that we can reduce the risk of recurrences. So these trials are the reasons why we're able to shift these therapeutics. These are the trials that allow us to take people off therapy. And I'm glad that this center is here. I'm glad that we have patients who are willing to participate in these trials for us to move the therapies forward and benefit a bigger patient population than just themselves. So this is one of the other Morpheus neoadjuvant study that's accruing fairly well. Keymaker, you are to see that Justin Moyers hinted towards. They have multiple arms looking at various combinations for neoadjuvant setting. And that's where I'll end my piece.